Welcome. My name is Spero Cataland from the Ohio State University in Columbus, Ohio. It's my pleasure to give this webinar today entitled Diagnosing and Managing TTP, Supporting Implementation of the ISTH Guidelines. And specifically, the talk is entitled Monitoring of Immune-Mediated TTP. What should I be doing after the platelet count is normal? So going back to Dr. Moskowitz's initial description in 1925 of a case of a 16-year-old female, a high school graduate, if you will, of the business school as well, employed for 8 months, who after a weekend at the beach awoke with weakness, pallor, constipation. Petechiae were reported in this case report. There was no platelet count described. But unfortunately, what was described is a course over approximately a week to week and a half of progressive decline in her condition, eventually leading to paresis of her left arm and leg, coma, irregular respirations, and death. And what is seen in this figure is the microscopic section of the arterioles from her heart, showing microvascular occlusion of the arterioles of her heart, which likely ultimately led to her death. And this really is intended to point out the importance of microthrombotic disease in TTP. Sometimes the low platelet count is seen and is thought of as a bleeding disorder, but there's no question this is a thrombotic disorder. And the complications and the mortality that happen are without a doubt related to the chronic and ongoing microthrombotic disease. In the figure on the left, you can see in the top, under normal physiologic conditions, under blood flow and shear forces, the ADAMTS13 protease will cleave this secreted BWF, the von Willebrand factor, into the physiologic sizes where it can mediate thrombosis where it's required and needed. In the pathologic state below, there's either a congenital deficiency or an acquired immune-mediated clearance of the ADAMTS13 protease. You don't get metabolism of these ultra-large von Willebrand factor multimers down to the physiologic sizes, but rather the ultra-large BWF multimers circulate, bind platelets, and lead to this microthrombotic disease. That is really the hallmark of TTP. It's very interesting to look at the evolution of the clinical syndrome over time. And over time, when there was no known treatment for TTP, starting to get into the window toward the end of the 70s and 80s, where there is an effective treatment plasma exchange and more modern times. You can see the death rate declines over time from 90% down to 22%, which is fairly close to today's levels. But I think what's also interesting is this pentat of TTP as it was described, where it was nearly uniformly present in all patients, given the time-dependent follow-up of these patients and their progressive course, to where plasma exchange and treatment is now more readily available, and you start to see patients treated early before all the pentat is fulfilled. And you can see now in more recent times, really all that's required is thrombocytopenia, fragmented cells, or a hemolytic anemia, and really no other explanation for these findings. This is all driven by the need to rapidly initiate therapy with plasma exchange to not miss any cases and avoid morbidity and possibly mortality. So it's important to discuss the terminology and really know we're talking about the same things when we describe clinical outcomes. A clinical response is defined as the normalization of the platelet count and LDH after stopping plasma exchange therapy. So it's really getting that clinical response, the normal platelet count, the normal LDH. Clinical remission is defined as the same, but this is maintained for 30 days after the last plasma exchange procedure. Exacerbations are defined as platelets less than the lower limit of normal and the need to restart plasma exchange in the first 30 days after the last plasma exchange procedure. In contrast, relapses are similar. They're the need to restart plasma exchange therapy, but it's 30 days after the last exchange procedure. Really, the differentiation here is to look at exacerbations as really a continuation of a prior episode and not a new distinct episode. And relapse is occurring more than 30 days after the last plasma exchange procedure as a new and distinct TTP episode. So exacerbations are a very significant clinical issue in the treatment of immune-mediated TTP. Again, it's defined as a recurrent thrombocytopenia in the first 30 days after the last plasma exchange procedure. Again, it differentiates a continuation of the prior event from a new distinct TTP encounter or episode. It will occur in approximately 30 to 40% of patients and is most commonly occurring in the first 2 weeks after the last plasma exchange procedure. And again, as I've already stated, I would emphasize it is a significant clinical issue. It requires typically readmission to the hospital, another central line placed for plasma exchange therapy, and an additional course of plasma exchange therapy, which may be just as long or longer than the first treatment course. Studies have been ongoing in our group now more than 10 years ago to try to understand the risk factors for exacerbation. And in this retrospective study, we looked at patients who either did suffer an exacerbation, 13 of 44 patients, and 31 of the 44 that did not suffer an exacerbation. You can see their clinical data at presentation, the platelet count, the LDH, are fairly similar. What came out from the initial analysis was that the pre-treatment ADAMTS13 activity was significantly lower in those that suffered an exacerbation compared to those that did not, 0.8% compared to 1.4%. Although that was very interesting, when the analysis accounted for other covariates, including African American race, the ADAMTS13 activity was no longer significantly predicting exacerbation versus non-exacerbation. And African American race actually was shown itself to be place patients at an increased risk for exacerbations. There have been several studies trying to look at different immune suppressive therapies, including cyclosporin, steroids, rituximab, trying to see if there is a clinical effect on exacerbations, trying to decrease them. Rituximab is used, and we'll talk more about this in preventing relapses, but rituximab is a monoclonal anti-CD20 antibody that targets B lymphocytes that produce these anti-ADAMTS13 antibodies. The intent is to suppress the production of the anti-ADAMTS13 antibodies to result in the improvement of the ADAMTS13 activity, clearly to prevent relapse, but also to consider if this might actually impact exacerbations as well. What you can see in the slide here, figure A from Dr. Scully's manuscript, is the gradual rise in the ADAMTS13 activity in the solid line, and the dashed line showing the decline in the IgG inhibitors of the ADAMTS13 protease. And as you can see, it really isn't until about the second week, day 10 to 15, that you start to see a significant improvement in the ADAMTS13 activity and the decline in the IgG concentration, likely occurring later than it can be expected to help with exacerbations, which tend to occur again more in the first 2 weeks. If you look at the data for long-term follow-up and relapses, there certainly is a decreased risk of relapse in patients treated with rituximab versus non-rituximab treated regimens. We'll talk about this more a bit later. So rituximab certainly seems to have a benefit on at least decreasing or delaying relapses, but does not seem to have a significant benefit on shortening the initial course or decreasing exacerbations. So switching to capitalism, the recently FDA-approved medication for TTP, and the TITAN study, should be highlighted that the mechanism of action of capitalism is one to bind to VWF, the A1 domain, specifically to prevent its interaction with platelets, essentially blocking the formation of microthrombotic disease. Really has to be emphasized that capitalism does not change the underlying physiology of the disease. It's the plasma exchange and immune suppressive therapy that's important to do that. Really a temporizing measure, if you will, very much analogous to plasma exchange therapy. In this TITAN study, there was a single-blinded study, one-to-one randomization for patients to receive ALX0081, or what is now known as capitalism, or placebo, along with plasma exchange therapy and standard immunosuppressive therapy per physician choice. One of the most important aspects of this study, I think, is the fact that the treatment was continued for 30 days after the last plasma exchange procedure to cover this exacerbation time period, which allows you to see if the drug can actually impact these exacerbations. If you look at the initial data from the TITAN study, they're certainly very interesting. And if you look at the capitalism treated patients, the median time to a response or a normal platelet count certainly was shorter than the placebo treated patients. This is a very good and objective metric to judge the efficacy of the treatment. But I think what's more exciting and more interesting is this marked reduction, this significant reduction in the exacerbations of TTP occurring in 3 of 36 patients, or 8%, compared to 20% of patients on the placebo arm of the study. What's very interesting to look at is after the drug is stopped in this 1-month follow-up period, you see 8 patients which are characterized as relapses because they occur beyond that 30 days. But what it certainly looks like occurred was the capitalism was protecting patients beyond that 30-day mark. When the drug was stopped, then this recurrence of their disease occurred. You don't see this in the placebo treatment arm, suggesting that these were exacerbations that already occurred. The other ones here on the capitalism arm, these 8, were ones that were destined to be exacerbations, but were blocked, if you will, by the capitalism. Certainly very interesting data. If you look at sort of the details of these exacerbations, and in the capitalism treated patients where there was 3 exacerbations, 2 of the 3 had severely deficient ADAMTS13 activity. And if you look at the placebo-treated patients, all but 1 were severely deficient, suggesting that this is a very strong risk factor for exacerbations, the severely deficient ADAMTS13 activity. And again, these relapses, these that occurred in the first month after, they were all 7 that had data analyzed severely deficient. So this is the schema for the phase 3 Hercules study of capitalism. Again, a randomized, double-blinded, placebo-controlled international study. It should be emphasized that this is essentially the same design as the Titan study, with the capitalism and placebo continued 30 days after the last plasma exchange procedure. But given the knowledge learned from the initial study where early recurrences could still occur after the drug was discontinued, if they were still ADAMTS13 deficient, an extension time period was allowed, essentially of 4 additional weeks of capitalism treatment to protect the patient while immune suppressive therapy could be altered, intensified, or changed to try to improve the ADAMTS13 activity. Any recurrences on the study were switched to open label capitalism at that point with no unblinding occurring. In this Hercules studies, you saw essentially similar data to the Titan study, where there was a significant reduction in the number of exacerbations that were suffered. 38%, again, consistent with the prior study of placebo patients suffered an exacerbation, and only 3 of 72 or 4% of capitalism patients suffering an exacerbation. A smaller number of patients suffering a relapse after the follow-up period, with, again, similarly patients having severely deficient ADAMTS13 activity, likely leading to this event or strongly contributing to it. So certainly we've talked about the efficacy of capitalism. I think it's very important to talk about bleeding. And essentially when you're talking about an agent that binds to von Willebrand factor, essentially inducing a VWF dysfunction or a von Willebrand disease, if you will, bleeding is what you might expect. And that's certainly what you see in the treated patients, where 45% of patients had a bleeding-related treatment-emergent adverse event. Epistaxis was the most common, gingival bleeding, bruising, and hematuria. In general, the bleeding that was seen was very manageable and controllable and really much easier to handle than the thrombotic phenotype it's really replacing with the treatment. So overall, you must be aware of these bleeding issues, especially when starting therapy, but these bleeding complication issues were manageable. So when and how should you discontinue capitalism? Persistent and severely deficient ADAMTS13 activity is a strong predictor of exacerbations and additional recurrences of TTP. Capitalism has been shown to effectively prevent exacerbations of TTP. So how should the capitalism be used after hospital discharge? How frequently should the ADAMTS13 activity be checked, and when should it be stopped? So this is a slide taken from a prospective randomized study we did at our institution comparing prednisone versus cyclosporin as adjuncts to plasma exchange, with the endpoint being exacerbation rate. There was no significant difference, but as you can see, the improvement in the ADAMTS13 activity happened more quickly in the prednisone arm of the study. So I would tell you to disregard the cyclosporin data here to just really focus on what happens to a patient's ADAMTS13 activity in those first 30 days after they're recovering from acute episode. This blue line represents patients treated with plasma exchange and corticosteroids at 1 milligram per kilogram. Prednisone was continued at full dose through week 4 and then tapered. So you can see the pre-treatment ADAM-TS13 activity. Week 1 then signifies the first measurement of the ADAM-TS13 that occurred at least 5 days after the last plasma exchange procedure. And you can see the subsequent change on week 2, 3, and 4. So again, similar to rituximab, it took really a couple of weeks to start seeing an appreciable improvement in the ADAM-TS13 activity and what we would presume to be a decrease in that risk of exacerbation. How this is relevant to capitalism-treated patients is, as there's been no direct study on how best to stop capitalism, the idea here is you want to continue capitalism until there's stable improvement in the ADAM-TS13 activity that is independent of any plasma exchange or infusion that would have occurred. So in general, we would like to see at least 2 consecutive ADAM-TS13 measurements that are greater than 20% to give us comfort that it is safe to stop the capitalism. Now, what's going to factor in this is the tolerability and side effects any patients might be experiencing, which may cause you to stop it earlier, potentially after one reading of 20% or greater if there are some complications or issues or hemorrhagic issues that the patient is dealing with. So certainly some guidelines, but nothing that's set in stone. So we'll switch gears here briefly and talk about relapse of immune-mediated TTP. And these are data from the Oklahoma group. And do a very good job of showing really what is the sort of natural history of relapse of TTP. We know it's most common in the first 2 years after the treatment, but this risk does not go away after these first 2 years. I think it's safe to say the relapse rate is going to be approximately 50% in all patients, but late relapses, as I just stated, can occur as well. We know the ADAM-TS13 activity is a good predictor of relapse that we'll talk about shortly. In this slide, you can see in the dotted line, the patients that were treated with rituximab, in the solid line, those that did not. You can certainly see the early recurrences that occur in the non-rituximab treated patients. So at a very minimum, the rituximab can delay, if not prevent, relapses from occurring. The ADAM-TS13 activity in remission is a predictor of relapse of ITTP. This was studied by Dr. Flora Pavandi and her colleagues in 109 patients with samples that were obtained and studied while in remission. This was beyond 30 days after the last plasma exchange procedure, but still in clinical remission and prior to a clinical relapse. The majority of patients had only one sample studied. What they found was the ADAM-TS13 activity, when less than 10% in remission, had a 2.9 fold increased risk of relapse compared to when it was above 10%. And when a positive antibody test was found with the severely deficient ADAM-TS13 activity, the risk increased to 3.6 fold. Our group did some similar work following patients in remission of their TTP. Our convention is to monitor patients every 3 months for long-term follow-up for the risk of relapse as well as these long-term complications. And in these data, you can see 157 serial samples from 24 patients. So the readout here is the probability of relapse, and it's a relapse that does or does not occur in 3 months following the ADAM-TS13 measurement. When the next ADAM-TS13 measurement occurs, the clock starts over. As you can see from all of these patient samples grouped together in the top panel, as the ADAM-TS13 activity decreases, the risk of relapse over the next 3 months starts to approach 10%, which really isn't so great. If you look in the panel below, though, when you break this down by age in different age groups of the 20s, 30s, 40s, and so on, you start to see as the ADAM-TS13 declines in the younger age patients, you start to really get a marked increase in the risk of relapse, where the relapse risk can start to approach 40 to 50% over the next 3 months in younger patients, raising the question and the possibility that there are other strong risk factors in addition to the ADAM-TS13 activity, age, and potentially others to help improve the prediction of relapses of TTP. It's also important to mention that just severely ADAM-TS13 deficiency alone does not uniformly or automatically lead to relapse. We talk about the second hit hypothesis and look at mice that were bred to have no ADAM-TS13 protease activity. These mice did not spontaneously develop TMA findings. Rather, something else had to be done. Shiga toxin collagen epinephrine was added, high doses of EWF, to initiate the development of this thrombocytopenia and this TMA-like picture in these mice. So this is that second hit that we talk about. In congenital TTP, we can certainly loosely talk about pregnant women as a good example of this second hit. And these are data from the French TMA group and Paul Capo, who looked at 592 adult onset patients, but with 42 with a pregnancy onset as their first presentation. So in patients who did not have evidence of an inhibitor, both in the titer and the IgG concentration, they found 19 patients and continued to follow them. And in remission, 10 remained persistently ADAMTS13 deficient, while 9 recovered the ADAMTS13 activity, making them more consistent with an immune-mediated acquired form of TTP. These 10 patients were then confirmed to have hereditary or congenital TTP. So it's very interesting that 10 out of 42 patients, or 24%, with a pregnancy onset of TTP actually had congenital TTP, which is greater than what would be expected in an adult presentation of congenital TTP. So this certainly demonstrates that these are patients who had a pre-existing ADAMTS13 deficiency, but that second hit was the pregnancy that led to the acute TMA episode. So as part of the ISTH TTP guidelines, there are good practice statements, which are not based necessarily on a strict and formal review of literature, but expert opinion on good practices. And one of these is the ADAMTS13 activity monitoring in remission. And certainly believe that patients should be assessed regularly during follow-up. The exact schedule for monitoring really is not recommended and has not been studied formally. In general, patients should be followed monthly for 3 months, every 3 months for the first year, and every 6 to 12 months going forward. There's obviously room for variation in how this may be applied. In a capitalism-treated patient, that follow-up is going to be weekly for the first month, which happens to be our convention as well, even independent of capitalism. It also should be noted that if there's noted to be a declining ADAMTS13 activity, more frequent measurements should be obtained to confirm this. You want to make a decision on the need for prophylactic immune-based therapy of TTP to prevent relapse on at least 2 measurements and not 1, given the fluctuation that can be seen. So in general, stable and durable ADAMTS13 activity near the level of normal is reassuring. Persistently lower levels of ADAMTS13 activity may be a risk factor for relapse. Just to touch on briefly some prophylactic therapy options, and we're only going to highlight on rituximab and splenectomy today, but rituximab, cyclosporin, as well as splenectomies have been reported to be effective prophylactic options to prevent future recurrences of immune-mediated TTP. And if we look at the ISTH TTP guidelines, recommendation number 6, for patients with immune-mediated TTP in remission, but with low ADAMTS13 activity and no clinical signs or symptoms, the panel suggests the use of rituximab over non-use of rituximab for prophylaxis. And this is really based upon the concern of the increased risk of relapse for the undetectable ADAMTS13 activity in a patient with a prior history of TTP. Data from Justin and all from the French TMA group looked at preemptive use of rituximab in immune-mediated TTP in patients in remission. So these are patients followed every 3 months, and when severely deficient ADAMTS13 activity developed, prophylactic rituximab was administered. You can see in this graphic in the red where prophylactic rituximab was administered, and in the blue line where these were historical controls where it was not. And you can certainly see a very obvious and significant difference in the relapse-free survival. It must be emphasized, though, that these are non-randomized data. There's not been any clear effect on survival demonstrated to date. That will take many more years, I believe. What also has to be considered is the patient commitment necessary for these serial monitoring of the ADAMTS13 activity, the potential issue of expense, and the potential issue of anxiety developing in patients who react adversely to knowing their ADAMTS13 activity is low, where relapse may not be absolute. Rituximab prophylaxis also without monitoring the ADAMTS13 activity is not an evidence-based strategy. So using the rituximab as a prophylactic should be combined with serial monitoring of the ADAM-TS13 activity to monitor its effect and to monitor when retreatment might be necessary. For preemptive or prophylactic rituximab, questions often raised is what is the most appropriate dose? And this study done from the UK TTP group in Westwood et al. Certainly looked at 3 different doses of rituximab. Standard dose of 375 milligrams per meter squared, an intermediate dose of 500 weekly times 4, and a reduced dose of 200 milligrams IV weekly times 4. This was rituximab given early in the course of their treatment with plasma exchange. And you can see the treatment-free survival in this graphic not being markedly different, the standard dose compared to the reduced dose. But indeed, when you look at it more carefully, there was a higher rate of retreatment required due to the recurrence of the ADAM-TS13 deficiency in the reduced versus the standard dosing arm of 0.38 episodes versus 0.17 episodes. So certainly the lower dose lended itself to needing recurrent treatment with rituximab prophylactic treatment sooner than the standard dose. It's also important to mention briefly splenectomy in the prevention of relapse. These data are now 15 years old, but certainly suggest the potential efficacy of splenectomy in preventing relapses of TTP. This was a study where 33 patients with TTP underwent splenectomy, but 24 underwent it for a prophylactic reason. Splenectomies have in the past been used for refractory TTP, but that is where splenectomies are associated with a greater risk of complications and potential issues. But in this retrospective study, again, of patients who underwent a splenectomy to prevent relapses, the median pre-splenectomy relapses were 2 with a range of 1 to 9. Again, pretty significant follow-up of 111 months with a range of 9 to 230 months. Relapses occurred in 25% of patients after a median follow-up of 15 months, some as long as 96 months. But certainly a decrease in the relapses per patient year seen in the splenectomized patients. So there certainly were recurrences, but certainly splenectomy did a very good job at preventing relapses in the majority of patients. Worthy of future study. So TTP and long-term follow-up, good practice statement. I think it's fair to say that it's more than just preventing relapse. This is based more on, again, expert opinion of TTP healthcare providers and not a formal review of the literature. But when you're following patients, you are monitoring the ADAM-TS13 activity to help to predict the risk of relapse and the need for preemptive or prophylactic therapy, but also monitoring patients for long-term complications of TTP that we know are significant in patients. Vascular issues, mood disorder, as well as many other chronic complications can be seen in patients. And much of the mortality that can be seen in patients with a prior history of TTP is indeed not related to acute TTP episodes, but can be ascribed to these long-term complications, I believe. And again, ADAM-TS13 activity monitoring in remission in ITT patients is very important. Again, now to predict this risk of relapse, but it may become important to try to predict the development of long-term complications of TTP. So now we'll have a case here of a 32-year-old female with a history of being diagnosed with immune-mediated TTP 2 years previously. At that time, she was treated with plasma exchange, corticosteroids, and rituximab. Since her diagnosis, she has done well, no significant medical issues or complications. She was initially seen by her hematologist after discharge from the hospital, but has not been seen since that time. Her laboratory studies now show a hemoglobin of 8.3, hematocrit of 26%, a normal platelet count of 189,000, and a white count of 15.4. Her serum creatinine is normal, and her LDH is normal at 154.